So today's webinar, which is number 22 in our series, is showcasing the value of geriatric trained healthcare providers for older Coloradans. So why are we focused on the subject of geriatric trained healthcare providers? And this is the reason. Our population is aging, and it's aging rapidly. As you can see here, this line is actually probably already crossed. You know, there are more people over 60 than under 18. And you often will hear the fact that Colorado is the second fastest aging state in the country. And that's based on this map right here that comes from the US Census Bureau. So you see that the dark purple shows a 60% and higher percentage change in the 65 plus population. And you see a lot of dark purple here in our state. So what I'm going to do now is introduce each of our panelists. I'm starting with Jody Waterhouse. All right, okay, Jody Waterhouse is the Director of Outreach Programs at CU Anschutz Multi-Disciplinary Center on Aging, where she's responsible for strategic positioning, program development, and implementation of programs and new initiatives across the medical campus, as well as throughout the state of Colorado. Jody works closely with all the health science schools, government, industry, and community organizations focused on aging across Colorado. Our next panelist will be Dr. Barbara Morris. Barbara is a practicing geriatrician and passionate patient advocate who works to improve geriatric strategies for clinicians. She has decades of clinical and administrative experience in clinical geriatrics, medical administration, and patient advocacy. Her clinical practice is at Stride Community Health Center in Lakewood, Colorado, where she is participating in Stride's journey to become an age-friendly health system, and she's going to be talking about that. She's a passionate advocate for patients and their families in assisting them to achieve their life goals. And in addition to her clinical work, she offers consultation and advocacy for patients, families, and practices via the Barbara Morris, MD, Geriatric Advocacy and Consulting. Our next panelist then will be Dr. Sunny Linebor. She is a professor, Department of Clinical Pharmacy at the University of Colorado, Skaggs School of Pharmacy and Pharmaceutical Sciences. Dr. Linebor graduated with her Doctor of Pharmacy degree from the University of Kansas in 1999 with highest distinction. After graduation, she then completed a residency at the Veterans Affairs Medical Center in Denver and a primary care residency at the University of Colorado. Since 2001, Dr. Linebor has provided clinical pharmacy services in geriatrics at the University of Colorado Hospital Seniors Clinic, and where she also precepts pharmacy students and residents. Her research and clinical areas of interest include transitions of care, cardiovascular disease, health promotion, osteoporosis, vitamin D, dementia, and urologic disorders. She's an active member of the American Geriatric Society and past president. She's also a member of the American Board of Internal Medicine, Geriatric Medicine Board. And our next presenter will be Dr. Sarah Dirks, DDS. She is an assistant professor at the UC Anschutz School of Dental Medicine with a focus on community dentistry and population health. Dr. Dirks was a dental faculty at the University of Texas Health Science Center in San Antonio for 18 years, completed her geriatric dentistry fellowship, and helped open the dental school's geriatric dental clinic. 2007, Dr. Dirks left academia to open up the first private practice in San Antonio to specialize in the dental care of older adults who live in the community as well as in long-term care settings. After selling her practice, she accepted an associate professor position at the University of Colorado School of Dentistry, Anschutz. Dr. Dirks is passionate about educating dental students in geriatric dentistry and working with community organizations dedicated to promoting healthy aging. She'll be directing the Seniors Dental Clinic at the dental school, which opens January 2023. So that'll be something new for folks to participate in. And our final panelist is Dr. Kelly Hendricks. She's now 8 years into her work as an assistant professor at the University of Colorado College of Nursing, teaching both undergraduate and graduate courses focusing on older adult nursing care, as well as diagnosis and management of chronic diseases. She's passionate about improving healthcare outcomes for older adults. Her most recent research focuses on improving nursing student attitudes toward older adults in community fall-based education, and also practices 1 day a week as a geriatric nurse practitioner at the UC Health Seniors Clinic at the Anschutz Medical Campus. I'm not sure everybody knows that there is a seniors clinic at the Anschutz Medical Campus, but it's been there for quite some time. And Jody, when you're speaking, you might want to mention the code as well. Mm-hmm. Next slide is just a little information about Agewise Colorado. And what we're doing, we're working to become that premier information and vetted resource hub for aging Coloradans and all current and future caregivers. And we use this to illustrate the point. We focus on folks who are living in this sandwich generation and as well as older adults. Between those two groups, there are close to 3 million people here in the state of Colorado. We have found through our data analytics from our website that about half of the people who come to our website are in this group and the other half are over here. We serve aging Coloradans, caregivers, as I mentioned, employers, providing support for current and future caregiving employees, and our vetted service providers as well, and all organizations committed to healthy and aging Coloradans. These are all of the categories of services that we have on our website. I would encourage you to look at our website if you haven't done that already. Just kind of poke around and see what's there. There's a lot of information. The webinars, like the one we're recording today, are all on our website, as well as our about 200 plus vetted service providers. Okay, so what we're going to do now, I'm going to stop this and turn it over to Jody.
All right, let's see if we can share our screen here. Can you see?
Yeah, we're good. Well, I'm seeing your notes page.
Let's just, yeah, we'll switch that.
Okay.
We'll swap there. How about that? Does that look good?
There you go. There
Great.
you go.
All right. Well, great to be here. Thank you so much, Bob and Barbara, for having me. And I'm thrilled to be joining this panel with my clinician colleagues that I get to hang out with daily. So I'm glad you get to know them as well, because they're absolute dynamos in their field. And we play in a big playground together and have lots to share with you today during this panel presentation. So I'm going to talk to you a little bit about the CU Anschutz Multi-Disciplinary Center on Aging, just to lay the stage a little bit about the role in academia that a center that focuses solely on aging has, both across campus as well as out into the community. By no means, since with our limited time, I can give you the exhaustive list of initiatives that we're involved in, both on and off campus, but hopefully whet your appetite enough that you'll want to visit our website and get more involved with us in the future. So we're no different than a couple of the other higher ed institutions across Colorado who also have centers on aging. So if you're on today's call but aren't in the Denver metro area, there is a terrific Center for Healthy Aging up at CSU in Fort Collins. We also have a gerontology center down at University of Colorado at Colorado Springs, and the University of Denver is our peer institution here in the Denver metro area. So sharing with you a little bit about what we do as centers on aging. So we are truly the central hub for all things aging on the CU Anschutz campus. We're really stood up by 4 pillar areas, and that includes research, clinical care, education training, and then certainly outreach and engagement. All of this is really the central hub for all things aging at the university. So we might be collaborating on a particular research project with the School of Pharmacy, but we're working on a social isolation initiative with our School of Dental Medicine. But then we're creating a new older adult research specialist with our School of Medicine. So every day I am wearing a different hat and working with all the different schools in college. Just to let you know, in case you're not familiar, CU Anschutz is comprised of a School of Medicine, School of Dental Medicine, School of Pharmacy, the College of Nursing, and then finally the Colorado School of Public Health. So we try to bring together our researchers and faculty to collaborate on potentially research, new program initiatives, new curriculums in geriatrics by using the Center on Aging as a catalyst for that work. So also very exciting work that has happened over the last year. Last December, so December of 21, nearly a year ago, it was December 21st, that we were notified that we became approved as an age-friendly designated university. And the age-friendly work is happening all across the state of Colorado. CU Anschutz is only a small piece of a very progressive state that we all live in with regards to age-friendly, and I'm going to talk a little bit about that in a future slide. But with purposes of age-friendly university work, what that means is higher ed institutions can apply to become age-friendly as long as they abide by some pillars and principles, which I'll share. But when we became age-friendly university last year, we were #1 in the University of Colorado system to be designated. We were in #2 behind our peers up at CSU. CSU led the pack for the state, which was terrific. We learned a lot from them. We're the #4 academic medical campus in the world. So for us, that's extra special because there's not many of us worldwide that at academic medical campuses are living and breathing the age-friendly work. And I think that Anschutz can be a true trailblazer in that particular area. At the time, last December, we were number 87. They are now at almost 100 universities worldwide that have become age-friendly. So the age-friendly universities, as I mentioned, here in Colorado, Colorado State University, just over the summer, CU Denver became age-friendly. And I know our peers down at University of Colorado at Colorado Springs are doing the good work to become age-friendly in 2023. So age-friendly work, when you're a higher ed institution and you apply to become age-friendly designated, what does that mean? Well, the global network for the age-friendly universities really has identified through extensive research 6 pillar areas that they would like higher ed institutions to focus their work. The 6 I have listed there, however, I have bolded the 3 that here at CU Anschutz, we really are focusing on first. I could have totally made a case to the chancellor that we could do all 6 of those. We have that happening across campus in all 6 pillar areas, but really to build upon our strengths as an academic research medical campus, we have chosen to start with research and innovation, intergenerational learning, and encore careers. And I'll give you some examples of that work in future slides. So in addition to those 6 principles, each of the higher ed institutions across the world also have 10 principles. And the 10 principles are really kind of our guideposts of the work that we do across campus as we are creating maybe new initiatives, as we're moving into research and innovation spaces that include older adults, or as we're training our future clinicians across all the different healthcare disciplines in geriatrics, which my colleagues will talk with you in a little bit. These principles are really our guiding lights to that work to make sure that we're doing it correctly. And here are some of the principles based on the 3 pillar areas that we've chosen to focus on. So age-friendly work across Colorado, I'm not sure how many of you are that know that, like I mentioned, it's a very progressive state. So we live in a pretty cool area within the country. Currently, we have age-friendly health systems to include clinics, departments, healthcare systems, at the CU Anschutz campus, at UCH, so at the hospital. Our acute care for the elderly, our ACE unit, just became age-friendly health system designated last month. So there's a lot of work being done in the health system space, and I think Barbara's going to talk a little bit about that later. Age-friendly livable communities. So back in 2018, the state of Colorado was the number 3 state behind New York and Massachusetts to become an age-friendly livable community state. And currently, we have 9 Colorado counties, 3 towns, and 8 cities who are age-friendly designated. We also have age-friendly public health system work. I've talked a little bit about the age-friendly universities. And I'm also, one of my roles is, I was appointed by the governor's office to serve as the higher education representative on the newly formed Colorado Commission on Aging. And we just identified 3 priority areas, and age-friendly work is included in the top 3. So you'll be seeing a lot more about age-friendly work across our state in many different sectors and industries. So to bring us just back to CU Anschutz, to give you an example of what a Center for Aging tends to focus on, the 4 pillar areas that stand up our center, our Multi-Disciplinary Center on Aging, include research, clinical care, education, outreach, and engagement. In an example, I'm going to provide for each of these areas. Again, like I mentioned, we have a number of initiatives under each of those pillars. So I will make sure to put in the chat our website, because I would love for you to poke around and see if there's anything that speaks to you to get more involved. But I'll highlight a few of the initiatives that we have currently. So living under our age-friendly umbrella, as we roll out new initiatives, we want to make sure that that fits. And one of our newest programs in the encore work, research, innovation, and intergenerational, so serves really all 3 pillars, is our older adult research specialist. And through a grant with the National Institute on Aging, we received a significant funding opportunity to build an infrastructure throughout the entire CU Anschutz campus, where we train older adults to join research teams and become the team expert around recruiting, educating, and retaining older adults in future clinical trials. So here at Anschutz, when we were putting together the grant, we pulled some statistics, which was quite interesting, that 70% of our workforce in the research area is under the age of 40. So we have a very young campus, which is exciting that so many young people want to go into research. However, when recruiting the most underrepresented population in research, and that being older adults, when they are young, trying to recruit older adults, sometimes there's a disconnect. So we've created this new workforce on campus where we have older adults joining now research teams to create this intergenerational learning opportunity with each other. So it's really exciting work. And like I said, we have more information on our website if you're interested. Moving on to the clinical care space, as Bob mentioned, we do operate for purposes of today's presentation. I thought I would put in here the seniors clinics that we operate across Denver Metro, and that includes our seniors clinic at UCH in the outpatient pavilion here in Aurora on the CU Anschutz Medical Campus, also down at our primary care clinic in Lone Tree. And then most recently, we opened a 3rd seniors clinic location in the Kavod retirement community, which is located in Cherry Creek, not only to serve the residents of the Kavod community, but also the surrounding residents in the Cherry Creek area. In order to be seen in our seniors clinics, there is a criteria. You have to be 75 years or older and diagnosed with at least 2 comorbidities. And my clinical colleagues will talk a little bit more about what it means when you're seen by a geriatric specialist. On the education, and this one kind of lives in couple pillar areas, and that under the age-friendly university work, intergenerational learning, but also on the clinical care as well as education pillar for the center is the COASTED initiative. And that stands for Connecting Older Adults and Students Through Interprofessional Telecare. It's quite a mouthful, so that's why we just refer to it as COASTED. It was a program that we rolled out at the beginning of the pandemic, where we provided an opportunity for older adults and our CU Anschutz health profession students to come together and build a social connection with one another to try and reduce social isolation and loneliness that we were all feeling. And in addition, older adults provide mentorship for our future clinicians of how better to communicate with older adults, what older adults are looking for when they go to see clinicians. So it's a fabulous, fabulous program that's entering now its third year across campus. We work with the majority of the schools in the college, as well as long-term care and assisted living communities and community members who are living independently in their homes. We've had over 400 pairings between the students and older adults, where they stay phone partners for at least an academic year and usually talk to each other once a week or once every other week. Back in 21, we won the actual Social Innovation Hub Award for this program and hope that it continues long, long, long into the future, even after the pandemic. So on the outreach and engagement side, we do quite a bit off campus as well as on campus. And this is really an area that I can connect campus with advocacy and policy work. And that's spending quite a bit of time down at the Capitol, where we're not only advocating for issues that directly impact older Coloradans, but also have had the opportunity to be a part of two bills, legislative bills, one which passed back in 2021. And our next bill that I'm working very hard on right now to get ready for the 2023 legislative session is around building a pipeline training program so that we can get more clinicians interested in geriatrics. Right now in the state of Colorado, we are in a dire shortage of clinicians who are specifically trained in geriatrics, and with the hope of not only a loan forgiveness, but also this additional training that we can inspire more to go into the field. So with that, I know we only have a few minutes together today, but I wanted to put my contact information, and I will also drop this in the chat. I'm happy to chat with you further about other initiatives that we have or get you more involved in the center. So thanks very much for the opportunity to share a little information today. Thanks, Bob.
All right, thank you very much, Jody. That was great. Our next speaker is Barbara Morris. So Barbara.
Well, thanks so much. Jody, I'm out of breath just listening to you, and I thought I could speed talk, but I think you take the prize. Thank you for all that great information. As Bob told you, I'm a primary care geriatrician. I work for Stride, and I've had the honor of working on our age-friendly project actually since early on in the pandemic. And so I'm going to take the opportunity to share with you what the age-friendly approach looks like in the care of older adults, particularly in the primary care setting. But I would highlight that these principles that I'm going to share with you and the approach that we've taken with the support of the Robert Wood Johnson Foundation and the Institute for Healthcare Improvement are really principles that apply throughout the healthcare systems that are trying to become age-friendly. And we are very proud at Stride to have achieved our level 2 recognition for age-friendly care. This is a graphic from our colleague Terry Fulmer, has done so much work in geriatrics and particularly about age-friendly care. And it really summarizes a lot of what Jody has shared with us about the age-friendly ecosystem, as Terry Fulmer refers to it, and where we are in that. And you've heard some big picture things already about the university and the city and state. And we're going to focus in now on this area about age-friendly health systems. But I want to make sure that we understand that this is really part of the bigger picture of our environment and how it fits in. But before we get to the age-friendly dynamic, we have to say, and I ask myself this every morning actually, but what is a geriatrician, or what is a geriatric doctor? And you can think about that for a while. But Hopkins has shared with us this definition, which is that geriatricians are primary care doctors who have additional specialized training in treating older adults, and they practice in multiple locations, including outpatient nursing facilities and hospitals. And most of you are probably aware at this point that most of us don't go to all of those places, but you will find folks specialized in geriatrics in each of those different kinds of locations. Geriatricians have additional clinical and/or fellowship training in geriatrics. My initial training was as a family physician, and then I've had extensive clinical experience and training in geriatrics and achieved my board certification in geriatrics some decades ago. Currently, to be board certified in geriatrics, physicians actually can no longer just take a test, have to actually do the fellowship. And of course, there is fellowship training in geriatrics at the University of Anschutz, which we're very lucky to have. There are additional specialized trainees in geriatrics who aren't physicians, and you're going to hear more about that from the other panelists, but nurse practitioners, physician assistants, we'll hear from the dental side as well, all can achieve specialized training and certification in the care of older adults. This is the age-friendly framework for health systems that we're going to talk about. The pillars are the 4 M's. Here at Stride, we say, well, really, there are actually 5 or 6, but we'll focus on 4. So we have what's called what matters most, medication, mentation, and mobility. And I'm going to go through each of these relatively quickly so that you can have an understanding of what these pillars are about. And then at the end, I hope to be able to show all of us how we can use those, even if we're being cared for in a general primary care setting and not in a specialized geriatric setting. What matters most? I hope some of this looks familiar to those of you who are joining us today, because it's really the pillar of our work in the care of older adults, and that's to understand goals of care and wishes for the future. I think all of you know that we've been working on these issues for many decades, but COVID has really taught us how quickly things change and how important it is for our family and loved ones to understand our wishes so that they can advocate on our behalf, particularly if we're unable to do that ourselves. And so taking a step back and looking at these issues is even more important, I think, than it was in the past. I'm not going to go through all these documents separately. I hope some of this looks familiar to some of you, but understanding of the different types of directives, including living wills, power of attorney for healthcare, as well as finances, which is probably the more common one, the 5 wishes document, which many of you will have seen, and very important to highlight the Colorado Most form, which is the form that allows patients and their families in a very specific way to delineate what their wishes are for advanced care and extraordinary measures or not extraordinary measures. And so as part of age-friendly care, we spend a lot of time working on not just getting these documents from our patients and their families, but understanding their wishes. And I really tell my patients that it's the conversation with family and loved ones that's so important, and the documents come next. And the documents are important, but the conversation with our families is really more important in my mind and my experience. What matters most also includes goals of care. And I think this is something that clinicians would fess up and say, hey, we've spent a lot of time in medicine focusing on what are really more the goals of the healthcare system and the doctor, nurses, and care team rather than the goals of our patients. And so age-friendly care requires that we take a step back and actually ask our patients what their goals are, and then write that down in the electronic medical record or wherever, so that we actually can understand what the goals of older adults are, and we can help to achieve those goals as their health interacts with those goals. Medication. I hope all of you are aware how important an issue this is for our patients and their families. And I know that Sunny is going to really get into this in detail, but this is an incredibly important issue for all of us, but particularly as we age. And, you know, this seems basic, I suppose. What are you taking? What's it for? Sunny will talk about these things. Should I even be taking it? What are the implications for my other illnesses, for my other medications? Are the benefits worth the risks? And so again, age-friendly care really requires that we spend a lot of time working on this issue. And again, you know, working carefully to understand what medication profile is best for each of us. I would emphasize this slow and steady wins the game here in terms of medication. I have learned the hard way that looking at a list of medications and saying, oh, let's get rid of this, let's get rid of that, that one's no good on a first visit really leads to disaster, actually. So we have to understand how a certain medication profile came about, and then we have to understand if there are changes that need to be made, how we can make those changes in a safe and steady way. And that takes a tremendous amount of work. And we are very lucky actually at Stride to recently have added a clinical pharmacist to our team who will be helping us with our age-friendly approach. Mood and mentation. So this again includes more than one thing. They go hand in hand, as many things do in the care of older adults. Age-friendly care requires that we assess mood and memory on a regular basis so that we can understand not only how they're interacting, but how we can help with each of these issues. So we do regular screening for depression and anxiety in primary care. And of course, if we find issues, try to help with those, not only with medications, but with non-medication approaches to mood disturbances. And of course, memory and cognitive change, a huge part of what we're looking at for older adults. And as part of our program, we are screening for memory changes with new patients and yearly, so that we can identify these changes early and hope to make interventions to prevent further cognitive decline. This is an area of huge research and huge interest. And I would say in the day-to-day lives of those of us taking care of older adults, mood and memory, well, all of these take up a lot of our time, but focusing on these areas in an integrated way, I think is really critical to us helping our older patients achieve their goals. And we are very lucky at Stride, as many other primary care locations are now, to have integrated behavioral health as part of our team, so that the primary care geriatrician or primary care provider doesn't have to do all this work alone. And I think that that is incredibly important. Mobility, you've heard a lot about this, I'm sure. Again, I keep saying every M is important, but they all go together. We do screen for mobility issues as part of the age-friendly care. We use a test called a tug test, where we see how fast people can get up out of a chair, walk a few feet and come back. The key, I think, in assessing mobility issues is then intervening. So assessment and intervention includes looking at the person's whole medical background, particularly whether medications are causing risk in terms of falling, making sure that we are providing opportunities for physical and occupational therapy. And my patients will tell you that they don't get out of my office anytime without some conversation of what their current exercise plan is. And I really want to highlight this for all of you in the community, because we know now, after much research in many different venues, that exercise of the physical body is critical to keeping our cognitive abilities in shape, our brain in shape. And the reverse is also true, which is exercising our brain, which we think of as a muscle, is critical to keeping our physical body healthy. And so having opportunities for our older adults to be participating in whatever kind of exercise is going to be valuable for them is really critical, and is a big part of the work we do in age-friendly care. All right, so that's a speed talk through what the 4+ M's are and how we're using them in our site. But the truth is, as you heard from Bob and others, we have this problem because we have a mismatch between those of us who are trained in the care of older adults in particular, who have more time to take care of older adults. And I feel very blessed to be in that setting. But we have very many older adults who are not going to be cared for in a focused senior clinic or geriatric environment. But I would encourage us not to feel hopeless about that. I think we've heard some already from Jody about the future in terms of training opportunities. And our goal at Stride, and I hope in other ambulatory locations and other parts of the healthcare system, will be to provide evidence-based training and information to all clinicians who take care of older adults, so that this paradigm can be used wherever older adults are being cared for. And hopefully those of us who have a particular passion and interest in the care of older adults can help our colleagues do a better job for their patients, which I know that they want to do. So my advice is, remember this slide, remember the 4 M's, no matter who you're seeing, whether it's a geriatrician or anybody else, and be your own advocate or be an advocate for your loved ones. And that means raising your hand and saying, well, wait a minute, how does that medication affect my memory? Or how does that recommended procedure affect my goals of care? Is that something I really want to do? Or, hey, I'd like to give you my documents so that you'll understand what my wishes are. So this is a place where I would suggest that we can't be shy when we're being cared for. And we need to make sure that who's ever on our care team understands how these 4 things interact with each other, and how by working together, we can really do better to achieve our health goals. So with that, I'd say my hope, and I hope yours, is that all older adults will be cared for by clinicians in a healthcare team who are proficient, who can provide patient-centered and age-friendly care that helps them achieve their healthcare and quality of life goals. Thank you so much, and with particular gratitude to our team here at Stride and the larger teams working on age-friendly care, and most importantly to our patients, because it's really from all of our patients that we've learned the most about this. Thank you, and be in touch if you have questions.
And I'd like to I'll just make one quick comment about one of the things that Barbara said, which is to ask questions. As I remember my mother, God bless her, she would never, ever question a physician about anything. It was like, this is what I was told to do, and I'm going to do it. So in spite of a lot of encouragement for me to change that, but it didn't happen. Okay, our next speaker then is Dr. Sunny Lenneber, and she's going to talk about pharmacy related issues. Thank you.
Thank you, Bob. Do you see the big screen, or do you see the notes page?
We're good. It's the big screen. Okay.
Thank you so much. I do want to echo, and we'll probably all say these same basic comments, that geriatrics is a wonderful place to work, and working with older adults is really rewarding, but it requires a team in order to be able to really meet the needs of our older adults. And so part of that team at the University of Colorado is the School of Pharmacy, and we're really fortunate to be able to work with the School of Medicine, the School of Nursing, the physical therapy program, the PA program, the public health department, dentistry program. So it's really such a blessing to be able to have all of those different schools and practitioners to be able to work with. And then at the seniors clinic, one of the great things about the clinic is that we do have a lot of those resources there. And so I'm going to talk a little bit about what the pharmacy program is like and what our pharmacy services are at the seniors clinic. But you may be in your mind thinking about pharmacy really as the community pharmacist and the person that you see at Walgreens or at CVS Pharmacy. And those are pretty common positions that pharmacists will have, but there are also pharmacists that work with older adults in assisted living facilities. Pharmacists serve older adult populations in long-term care settings, like in nursing homes or in skilled nursing facility sections of those facilities. We also see pharmacists rounding in the hospital setting, and so taking care of our older patients who are admitted to the hospital or in the ICU. And then like myself, I work in the seniors clinic. So we have pharmacists who are embedded in ambulatory practices. We have pharmacists in managed care settings like at Kaiser. We have, and a lot of these are clinical pharmacists. So they are working in a pharmacy, or they may be, for the most part, working in the physician's office. So there are a lot of different places that you'll run into pharmacists. But when we think about the pharmacy training that's in geriatrics, it can be extremely varied. So some pharmacy students will get specialty training within their pharmacy program. And that could mean, for example, at CU, we have an elective in taking care of older adults, and it's an interprofessional elective. So some students will take that elective, and then they also are learning specifics about taking care of older adults within different courses related to specific disease states that are prevalent in that older adult population. Pharmacists can also obtain residency training after they graduate with focus in geriatrics or in specialty areas that are, like, for example, in the nursing home. So you do see pharmacists after graduation pursuing advanced training. And then we also have board certification. So like Dr. Morris mentioned, the professionals within the medical campus do have programs that are allowing them to obtain board certification. So we have BCGP, that's board certified geriatric pharmacists. We have about 4,600 in the United States and in a few other countries outside of the US. But this board certification is one that really helps to ensure and recognize the training in drug information and the aging process. We also focus on complexities of medications and illnesses that are common in our older adults. We learn and are tested on, like Dr. Morris said, through an exam to help resolve complex medication-related issues, prioritize medication-related issues as well. And then we also have advanced training in understanding Medicare and Medicare Part D drug coverage. So there are a lot of different places that pharmacists may practice. You'll most likely see the geriatric trained pharmacists within the settings like skilled nursing facilities and assisted living facilities. I just want to cover a few things on why it's important to have that training in taking care of older adults. And when we think about medications going into our bodies, many times all the way from the pediatric age up until the older adult age, people are taking medications. When we think about pediatric patients, they may be taking Tylenol or ibuprofen, things that are over the counter. Sometimes they do need prescription drugs. But as we age, we start to have more chronic conditions that will sometimes necessitate medications. And when a person is in their 20s or 30s, the drug going into their body can be very different in terms of how it affects the body and how the body affects that drug. And this changes over time. So when we think about a drug being taken orally, absorbed in the gastrointestinal tract, distributed throughout the body to the site of action, which also can increase side effects. We also think about the medication going through the liver and being metabolized and eliminated through the kidneys. And all of these systems within the body can be affected by age and other comorbidities. And so it's important to recognize that taking an aspirin when you're 20 is not the same thing as taking an aspirin when you have several medical conditions and you are of advanced age. So because of that, it's pretty complex. And we often will see side effects occurring in our older adults strictly because of these changes. We know, and Bob mentioned, that older adults make up a large population within the United States. It's about 13 to 14% currently. The baby boomers turned 65, which is sort of how we describe the older adult population based on Medicare definitions, but that baby boomer group turned 65 in 2011. So we've seen an increase in the number of older adults, and then a disproportionate amount of older adults taking prescription drugs, over-the-counter drugs, and then unfortunately having drug-related hospitalizations and making up half of drug-related deaths. So a lot of my job as an educator, as a clinician, is drug safety. When we think about things that you can do, as Dr. Morris mentioned, it's often difficult to be able to secure geriatric training within all your healthcare professionals. And so being an advocate, like she mentioned, is so important. And specifically related to medications, it's really important to have a healthcare professional review your medications in detail at a minimum once a year. And this not only means prescription drugs, but also over-the-counter medications and supplements. You would be shocked at how many drug-drug interactions and side effects can occur from what we might consider natural supplements that are on the market. So it's really important to be including all of your medications in that drug review. One of the things that can help is making a list of the questions that you have when you talk to your healthcare provider so that you don't forget or get sidetracked and you miss an important topic. It's really important to be upfront and honest. So if you're not taking your medication or your family member is non-adherent to their medication, it's important to say that to the provider because of course there are probably reasons that that's the case. And what we don't want to do is be assessing that patient and increasing the dose of the medication when really they weren't taking it at all. It's also really important to keep everyone up to date because many patients will have their primary care provider, they may have specialist providers, and so making sure everyone's on the same page related to the medications is very important. But we do unfortunately see a lot of medication-related problems, and you can see here that the couple here is trying to balance all their bottles. Hopefully this is not you at home with all of your bottles, but what we will sometimes see is that when patients are taking multiple medications, there's usually some that are ineffective. There are some that may have undesirable side effects. Some will have drug-drug interactions. Some are often too costly and can sometimes lead then to non-adherence. Some of the medications, the risks will often outweigh the benefits for a particular older adult. Sometimes it's just forgetting to take your medications. Sometimes the dose is too high, especially for kidney function. So we really have to be keeping an eye on that. And then we will often see the prescribing cascade. And I just want to take a minute to talk about this. The prescribing cascade is something that is very common and is something that we can stop. And as a patient, it really helps if you're involved in helping to stop this. And the way that I describe the prescribing cascade is by using this story. There was an old lady who swallowed a fly. So some of you may be familiar with this. It's a Caldecott Award winner. And it's the basic premise of this is there is an older lady, she swallows a fly and she thinks she might die. So in order to catch the fly, she swallows a spider. And in order to catch the spider, she swallows a bird. And in order to catch the bird, she swallows a cat. And in order to catch the cat, she swallows a dog, and so on, which is kind of crazy. But it is very similar to what you might see when you think about the prescribing cascade. So let me show you this in action. And unfortunately, this is something I do see on a regular basis. So we have a patient who has high blood pressure and they're started on amlodipine. This amlodipine is the fly. So the fly goes into your mouth, the amlodipine, it's actually a good choice for blood pressure. It works really well. It's pretty well tolerated. But one of the side effects is lower leg or ankle swelling. So the patient reports this lower leg ankle swelling and the provider says, oh, we can treat that. So we're going to start you on a water pill, like a diuretic. This water pill is now the spider going in to catch the fly. So then the water pill makes you lose electrolytes. So you get some leg cramps and you're like, gosh, these leg cramps are really bothering me. So your provider starts you on a potassium supplement to treat the leg cramps, which is appropriate if your potassium is low from the diuretic. Now you have stomach pain because potassium is pretty acidic and causes some stomach pain. So now you're started on a stomach medication, for example, omeprazole, which is over the counter as Prilosec, also as a prescription. Omeprazole does help with stomach pain, but it also causes diarrhea. And one of the side effects is increased risk of a bacterial diarrhea called C. diff. All of a sudden, now you're hospitalized with C. diff. So what started out as 1 or 2 medications, the blood pressure, the amlodipine, which is the fly, now has led to 6 medications and a hospital stay. So this is what we call the prescribing cascade. And I bring this up because what we want to do is we want to pull that fly out of your mouth. We pull out the amlodipine. We either reduce the dose or we stop it and switch the patient to a different medicine, and we stop that prescribing cascade. What you can also do, besides talking to your provider and making sure that you are reviewing your medications at least on an annual basis, is also store your medications safely. So we want to keep them out of reach of kids, out of sight of kids, and potentially locked if there are controlled substances. I just want to touch on this briefly because this is one of the initiatives of the campus, but storing medication safely is really important because a lot of our older adults have teenagers or children that could potentially access their meds. And teens say that prescription drugs are easier to get than beer. Also, in a surveys of Colorado teens, they believe that prescription drugs are safer to use than street drugs because they're prescribed by a doctor. So we want to make sure that we're not allowing some of our medications to go into the hands of those who may not be prescribed the medication. Also, pain medications rank 3rd among substances causing fatal poisonings of children under 6, and 5 of the top 10 causes of dog poisonings are medications found in the home. So we really do want to be careful and make sure that we keep our medications for ourselves. Now, of course, that has to be balanced with making sure that the medications are accessible to the person who needs to take them on a regular basis. So we do think about balancing the safety of the medications with others in the household, and then making sure that we are able to remember to take our pills ourselves. And as Dr. Morris said really well, this is an area, medications and you are an area that we really need to be working as a team. We need to work with our caregivers in that team, and we need to make sure that we are negotiating our patient goals, that we're not taking medications that we feel uncomfortable with, that our patients are having side effects from. So please do what she mentioned and ask questions, advocate for yourself, advocate for your caregivers, and really take the time to make sure that your medications are right for you and your loved one. Thank you.
Well, thank you very much, Stenning. And I had a quick question for you. So
Sure.
You mentioned the board certified geriatric pharmacist typically found in a skilled nursing facility or assisted living. Is there a list somewhere that people can look at and say, oh, this, my pharmacist at Safeway is geriatric certified?
Yes, so that's a great question, and I'm happy to send you that link in order to, I can put it into the chat, the link
Okay.
to look up. There are initials, so after a person's name, they may have PharmD, BCGP, and that would indicate that they are board certified. There are other board certifications as well. So we have, outside of geriatrics, we have primary care, we ambulatory care, we have other like ICU certifications, infectious disease, cardiology, that kind of thing. So you'll see other initials as well, but I'll put in the chat the website.
Thank you very much. Okay.
Sure.
That was great. Thank you very much. Okay, Sarah, you're up next.
Okay, can you see my slide?
Yes, we can.
Okay, not a lot of people have heard of geriatric dentistry. In fact, when I was in private practice, people would ask me, are you a normal dentist? And I would say, well, it depends what normal is. But one of the reasons that geriatric dentistry is not that well known is there really not that many dentists trained specifically in geriatrics. And I want to found a little bit on something that Jody said, as University of Colorado is a trailblazer, but having moved from Texas recently, I would have to say the entire state of Colorado seems to be a trailblazer in age-friendly efforts. And so I'm real excited to actually be in Colorado and see all the momentum that's going on. In fact, I'd only been here a few months and I heard about Sunny Lindenberg, who's a geriatric pharmacist. I don't think I even met one when I was in Texas, and I'm sure they're there. But Sunny lectured to my dental students in my geriatric course, and I don't take that for granted. I think that just is another example how Colorado and the university is a trailblazer in geriatrics. So what's the difference? All right, there we go. What's the difference between a trained and a not trained geriatric dentist? Well, you have to do a fellowship, postdoctoral fellowship. Sometimes they're 1 year, sometimes they're 2 years. I was lucky to be able to do one through the Health Resources and Seniors Administration. It was a federal grant that paid for my fellowship in conjunction with the Veterans Association. But in order to be geriatric, you have to have post-dental graduate training. A geriatric trained dentist is going to really use a total patient approach. I like to tell patients and people that we're not as much focused on teeth as maybe a normal dentist, but we are looking at all sorts of other things that really are just as important to the patient as their oral health. For example, if you have a patient in a wheelchair, how do they transfer into a dental chair? In my private practice, I had wheelchair lifts, so we would not have to transfer the patient. And even better yet, patients don't necessarily want to transfer. So we would have wheelchair lifts. We also provided mobile services to assisted livings. So a geriatric trained dentist is going to be someone who's very comfortable working with other professions. They're going to be able to work with social workers to maybe help with funding. They're going to be comfortable with doing extractions on somebody who has blood thinners or on bone altering medications. They're going to be familiar with nursing home regulations, which maybe a normal dentist would not necessarily be familiar with. I'm having trouble forwarding my slides. Let's try this. I'm kind of frozen. Bob, can you forward my next slide? There we go. So I'm going to answer just one question in 3 different ways, is how have I used my geriatric training to provide care? Well, mostly it's to overcome the barriers to care to get into a regular dental office. In my practice, the typical patient would not be someone who just calls up, says, I need to see the dentist. You're often working with family members. You're working with long-term care associations or long-term care settings. And you're working with physicians who may refer a patient. But some of the barriers to care are things like transportation. How is that older adult going to get to your office? How are they going to? I've had patients who with their electric wheelchairs could not fit into the average dental office's opening to their office. You used to dealing with hearing loss issues, limited visions. You have to be prepared to work with people who have fixed incomes and be able to offer them options that are lower cost. I've used training to help family members, caregivers who have loved ones with memory care and dementia issues. So there's a whole list of things that my geriatric training has offered and helped me to provide better care. And many of them have nothing to do with teeth, but I will mention a few things about teeth. So a dentist cannot do a presentation without showing a mouth. So I apologize, but if you look to the picture on the far left, you will see that this is an older adult mouth of a patient who got years of excellent dental care. They had gold crowns. They saw the dentist regularly. But what's very typical as we age is what I call is the perfect storm. Our medications, our dry mouth, our inability to get to the dentist can cause rapid decline. And so a geriatric dentist would look at that mouth on the left and perhaps to look at that tooth on the right that has a filling that may be starting to deteriorate. And our first reaction isn't, oh, we have to replace everything. Oh, you need expensive dentistry. We need to do crowns. That is not the first thing that I would think about. The first thing I would think about is, can we do something very conservative and low cost? And I want to mention one specific product that I think you should ask your normal dentist or your general dentist if they use, and it's called silver diamine. And if you look in that picture where I'm applying silver diamine around a crown that has some decay, and the silver diamine will actually stop the cavity without replacing the crown. Now, you can't use it on all situations, but I would say with the older adult mouth, where you have a lot of cavities, a lot of problems that keep coming up, there's some cost-effective solutions like silver diamine, which was just approved by the Food and Drug Administration in 2014, I believe. And then in 2015, there's a product on the market. So I use silver diamine frequently. I would have used it on the patient on the left. I would have used it on the patient on the right. Certainly, if a patient can tolerate regular, comprehensive, intensive care, that can be an option. But a geriatric dentist is going to be able to provide some more low-cost options to save teeth. Another thing that my training has helped me provide is just very simple, cost-effective ways for a patient, an older adult, to better take care of their teeth every day. Something as simple as a washcloth with a rubber band around a toothbrush, which anyone can do, can help with dexterity problems. There's toothbrushes on the market now that actually at one time brush the inside of the teeth and the outside of the teeth, and you can buy those on Amazon. There's videos and trainings on how to provide effective daily oral care for patients with dementia who may resist care. I want to give one other example. My geriatric training has really taught me to minimize tooth extractions as much as possible. For example, a geriatric dentist is not going to look at a tooth and say, it has to be perfect. We're going to look at teeth and say, well, what happens if we extract the tooth or multiple teeth on an 80-year-old? What's going to happen to their bone if they live to be 100? In the patient on the left, this is a lady who was very robust for her age, but she had gotten so many extractions that her mouth actually shrunk. And it was impossible for me to even get a denture tray in her mouth to make her a denture. She couldn't get a denture in her mouth. So I was very blessed to have a great lab who actually, if you can see on the right side of the photo, made me a denture that was flexible. And so that she could actually flex the denture to get it in her mouth and then it would relax. So my geriatric training has enabled me to look at each patient separately, to try to solve problems, and also try not to create problems that are going to be inevitable if we start extracting too many teeth on someone in their 70s. I mean, when I get a patient in their 70s, I'm predicting that they're hopefully going to live 20 more years. So I have to look to the future. I have to expect some frailty, and I can't expect every patient that comes into my office to be a candidate for implants. We have to really look at more conservative options. The last thing I want to mention is my geriatric training and my working within the interprofessional sphere has been incredible. I've worked with nutritionists, pharmacists, nurses, physicians, and I've learned that I've got a better appreciation of the role of my role in helping enabling people to eat. And as I tell my students, food will meet the metabolic demands of the body. Nutrition is essential for illness, healing, but meals hold a very significant psychological, physical, social, and even spiritual meaning. Anybody who had a Thanksgiving dinner with their family recently knows that mealtime is good for the heart and good for the soul. So when I try to improve an older adult's oral health, I'm looking at it more from a big picture point of view and how that might affect their quality of life. Finally, I want to give just a list of some questions you should ask your normal dentist, and something very simple. My favorite is number 2. Is it necessary to tilt me so far back in the dental chair? I've been into the dentist recently, and a lot of times that you will get tilted back all the way. I'm not saying that's a bad thing, but I never tilt my older adult patients all the way back. That is not good for them. They can get dizzy, they can aspirate. So that's one question. If you don't feel comfortable being tilted all the way back, say, is it necessary? Make sure you get all the treatment options and ask your dentist, what if I choose to do nothing? Could you actually paint silver diamine on my cavities as a stopgap? Or are my extractions absolutely necessary? I think once I got my geriatric training, I really started to rethink about my criterion for extracting teeth. Because once you extract teeth, you lose bone and you can't get it back. And your patients may not be a good candidate for implants. And as Dr. Setti mentioned earlier, how do medications affect you? How do they affect your oral health? How will the medications affect your dental treatment? Will I have to be taken off a blood thinner before I get a tooth extracted? And really, one of the ones that I really have focused on is most of our older adults are on fixed incomes. Are there lower cost options? Ask your dentist. Is there a lower cost option? What happens? What are my risks if I do the lower cost option? And what happens if I choose to do nothing? Rarely is doing nothing an option, but I think when you go to your dentist, you need to see and understand all the impacts of the treatment options, including what happens if I decide to do nothing. So thank you very much for this opportunity. And that's all I have for my portion today.
Well, thank you, Sarah. That was really informative. I mean, I appreciate that very much. And could you just mention where the seniors?
Yes, I would like, and thank you for asking that. The dental school here on campus has a special care clinic already. And what we're doing, we are expanding it to take older adults who may have a couple medication issues. They may be on dialysis. Their normal dentist may not be comfortable treating them, or they may be looking for some options. And it's located in the dental school, and all of our new patients get a free screening, a free consultation if they just want a second opinion. And that's what I'm trying to teach our dental students, really the more conservative approach. And 20 years down the line, I mean, most of my patients in private practice were over the age of 85, and they were still living 10 more years. So we have to think longevity. Thank you.
All right, would you put the address of that facility into the chat, please?
I certainly will. Thank you.
Okay. All right. Thanks so much, Kelly. You're up next.
Well, thanks for having me. It's 12:45, so in the interest of time, oh, wrong, is that, can you see? Oh yeah, good. I have two screens, just want to make sure you're seeing the right one. I will be brief. I think a lot of the things that I wanted to say were covered by other people on the panel, especially the physician from the Stride Clinic. So I just wanted to tell you a little bit about me, about my role as a geriatric nurse practitioner, how that differs from a physician or a PA, and just kind of my functions in the seniors clinic. And then I'll talk a little bit about the seniors clinic too. So as I said, as a GNP, I practice 1 day a week, and then I also work in the work over at the College of Nursing on the Anschutz campus. I teach in the undergrad and graduate program, and really try to infuse my passion for older adults into my education. I insert a lot of anecdotal things from my clinical practice about, people that I've met, stories I've been told, clinical situations I've been a part of. And I do think that bringing that element of my practice into my education provides a richer educational experience for the students. And I feel really passionate about, increasing their desire to work with the older adult population, because as Bob said, it's only going to be growing. So I make sure that that's very evident in my course. And then I also, I'm currently studying, what does influence our nursing students to want to work with this population after graduation. Unfortunately, a lot of research has shown that traditionally nursing students do not desire to work with the older adult population, or not many of them desire to work with the older adult population after graduation. So, how do we increase that intention? How do we infuse that desire and passion to work with this population after graduation? So that's actually one of my research areas, is nursing students toward older adults and how we improve them. And then, if we can improve their attitudes, does that translate to them wanting to work with older adults after graduation? The research that we have shows that the better the attitude of the staff that's taking care of you, the better the patient outcomes. So that's why this matters, is that we want passionate people who care about you, taking care of you, because that improves health outcomes in the long run. So that's one of my research areas. So while I'm teaching, I do a lot of educational research and trying to find the best methods in which to educate our students to do this. And then I'm also working with a colleague on community fall prevention. Falls seem like such a benign thing, but falls can be a matter of life and death, to be honest, not to be morbid, but it is, if you fall and break your hip, need to have hip surgery, there's just so many things, complications that can go along with that. And we really want to avoid that at all costs. So I've been working with a colleague in doing community fall education and prevention, and trying to help older adults with their mobility, their balance, and really keep them moving to keep their strength up and keep them feeling vibrant. So I just want to talk a little bit about what a nurse practitioner is. I mean, I'm sure everyone's heard of a nurse practitioner, but I do think that there's probably still some ambiguity just around the term. In general, our training, so we are all nurses. There's no requirement though to become, you don't have to be a nurse for any specific amount of time before you become a nurse practitioner. So for instance, I was a nurse for 5 years before I graduated with my master's degree as a nurse practitioner. So all nurse practitioners have an undergraduate bachelor's degree in nursing, and then they also go on to more school and get a master's degree. That master's degree includes extra classes in disease management, pharmacology, pathophysiology, advanced assessment, and just really, helping us to transition from more like a bedside nurse role to a provider role, because there is a pretty different set of thinking that goes along with that. Specifically, my training in gerontology as a nurse practitioner, my clinical hours in graduate school were focused on an older adult patient. I actually did some of my clinical hours in the seniors clinic here on campus. And then I also took additional classes that were focused on the aging body and how that, influences different systems within the body and the disease processes that can be the consequence of that. Roles of a gerontologic nurse practitioner. I used to work in as a primary care provider. I would go to skilled nursing facilities, assisted living facilities, nursing homes, and provide care to people that don't necessarily have transportation to an outpatient brick and mortar building. My role currently is in the seniors clinic here on campus. We also have a seniors clinic down in Lone Tree. And, as everybody has kind of talked about, the big advantage of, having a gerontologic trained practitioner, whether it's an NP or a PA or a physician, is that, we do have specialized education in those disease processes, how medications might interact. We have more access to resources like social work that can help with transportation. Sunny works in the seniors clinic to help me if you're already on 15 medications and I need to prescribe something different, how does that interact with the other 15 medications you're on? So these are really important things to keep in mind in an older adult patient versus a 25-year-old patient, like she was saying, that doesn't really take any meds or just takes Tylenol. It's very different in a geriatric patient. So I look at my role as, I am a primary care provider for older adult patients. With that specialized training, I feel, I can do the same things that a physician can do. I didn't go to medical school, but I have all the same functions in terms of I can perform assessment, I can prescribe drugs, I can, provide advocacy, referrals to specialists. So everything that your physician does, I can do. Are you the same as the physician's assistant? I think that this is a really great question. And I think that I love educating people about this because I get called a PA all the time. It's confusing. So we are not the same. However, we function in very similar roles. So a physician's assistant is a person who is not a nurse. They go to physician's assistant school, which has a didactic component where they learn, the book things. They go to, their classes and they take pharmacology and they take a lot of the things that I take that I took in my master's program. And then they do a lot of clinical time. They are more of a physician model, whereas a nurse practitioner is practicing more in the nursing model. And when I think of a nursing model versus a physician model, neither one is better or worse. There's just a couple differences in that nurse practitioners tend to be more holistic in their focus. We try to take into account, all the different elements of your particular healthcare situation, not only your healthcare situation, but your personal life and your significant others, where you live. And it's just more of that holistic planning. So a physician's assistant is more of the physician model, that biological approach to disease, not necessarily as much of a holistic approach, although certain PAs certainly can do that. So it's just about finding the right provider for you, of course, whether that is an MD or a PA or an NP. I just hope that you can find someone that you really build that rapport and relationship with, and someone that you really trust to be making the best decisions for you and your family. And in the last couple of minutes, I just want to, advocate for how I can add to your care, or any person with geriatric training. A lot of the panelists, again, talked about a lot of these things, but I really do consider myself to be a really strong advocate for you, and, how I can help you achieve not only your health goals, but maybe you have personal goals. And so how, maybe you want to travel, but you're on oxygen and you can't. So how do I advocate for you to accommodate that process? I consider myself to be a really good listener. One of my mentors always said that's why God gave us 2 ears and 1 mouth. We should be listening more than we should be talking. I like listening to patients. I love their stories, such rich histories. As I said, holistic planning. So, not just your healthcare goals, but all elements, your spirituality, your cultural factors, everything that's part of you and what's important to you. I can make referrals if appropriate. Like I said, in the seniors clinic, we have a lot of resources that are all like very geriatric focused, like pharmacy, social work, behavioral health is another great thing. You can make referrals to that. And, as I said, I can be your PCP, but I also have specialized training in older adult care and how that's a little bit different than normal adult patients that are younger than 65. So thank you so much. It's 12:56. So I did that as fast as I could.
You did great,
Thanks.
Kelly. I have a quick question for you. You mentioned the research you're doing to get more nurses to take up this geriatrics track. So what drove you to do that in the first?
A couple different things. So first of all, I am very blessed to have wonderful grandparents. Unfortunately, all of them are passed away now, but so that's why I said was. But I have had a deep connection with all four of them and feel very blessed that they were all in my life. And so that was kind of the beginning of it. And then when I started as a nurse, when I was 22, I just found that my favorite patients were older adult patients. And so that really influenced me to want to pursue a geriatric nurse practitioner degree versus an adult. Also during that time was when my grandmother, who I was really close to, she passed away during that time. And I was able to help her in that journey and be kind of, her bedside nurse while she was going through that process in hospice. And, it was only a couple weeks, but I was, there helping change her linens and give her medications and feed her. And just felt that was a very special experience for me. And I felt very blessed to have that as well. So after that, it was kind of a sealed fate for me, but it's been very, very good to me. And I've loved every minute.
Wow. Thank you for what you're doing, and thank all of you for what you're doing. We really appreciate your time today and all this really great information that I learned a lot. So I hope everybody else that sees this also does. And I want to mention a couple of things. One is, Kelly, you were mentioning fall prevention. We did a webinar on fall prevention about a month or so ago, and it's on our website. And I would strongly suggest folks take a look at that. We had 4 panelists, one of whom is a geriatrician, or two of them were actually, and along with some other people talking about how you can actually prevent falls. And then the other thing I want to point out is, and remind everyone, is something that Jody mentioned early on and today, is this legislation that has been proposed to go through this legislative session that really amplifies and allows for money to do that geriatric training for all of the disciplines that we've talked about today, plus more. And that bill is going to require a huge amount of support and advocacy to get through the legislature. It's going to be introduced by Senator Danielson. She's the sponsor. But I can tell you right now, it's going to be a tough slog because it's going to cost money, and it's going to cost money every year. So we're going to need a lot of help. So, we appreciate any help that anybody on this call can provide. So with that, does anybody have any questions? We have like a minute left. So, and we can go over a little bit if we need to, but does anybody have any questions? Any of the audience today? Any other comments from any of the panelists? Okay. All right. Well, once again, thanks everybody. We'll be getting this up on our website probably first part of next week. Have to do just a little bit of editing, and we have a volunteer that does that. So we'll get that done and and then we'll let everybody know when it's available. So thanks once again and have a great day. All right.
Thanks,
enjoy your-
everyone.
Thank
Bye.
you.
Thanks.
Bye-bye.
Bye.